Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content regarding a call to action for ensuring patients who test positive for hepatitis Delta are linked into care. During this podcast, Dr. Kosh Agarwal, consultant hepatologist and transplant physician at the Institute of Liver Studies at King's College Hospital NHS Foundation Trust in London, and Dr. Graham Foster, professor of hepatology in the liver unit and consultant hepatologist at Queen Mary University of London, discuss steps to take after a patient tests positive for hepatitis Delta. For more information about Dr. Agarwal and Dr. Foster, and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Agarwal and Dr. Foster have to say about the hepatitis Delta care cascade.
Hello, I'm Graham Foster, and I look after the liver service at Barts Health in the East End of London. And I'm joined today by my good friend Kosh Agarwal, and we're going to talk about hepatitis Delta and the challenges of finding people and getting them linked into care. Kosh.
Thanks very much, Graham, and great to be involved in this podcast with you. My name is Kosh Agarwal, and I'm likewise quite close to you in South London in King's College Hospital, London, and I head up for my sins the hepatitis service there, and also am a transplant hepatologist. And it's great to be discussing this important topic and this orphan disease and considering the issues around it and linkage to care and other aspects.
It's the D virus, the difficult one, with an aggressive course, a bit of a challenging diagnostics. But I think we're at the stage now where we've got our diagnosis established, and it's a question of how do we take these Delta positive patients and get them engaged in our services. So let me just start the ball rolling, Kosh, by thinking about a Delta antibody positive referred in from primary care. We've got some switched on GPs who are doing Delta testing routinely. I think most of us agree that all surface antigen positives should have a reflex Delta antibody. But as he pitches up to your clinic, clutching his Delta antibody positive test, where would you think we should prioritise? Where we should go first, Kosh?
So first of all, I'm going to take you back a step. I think it's really important to re-emphasize the importance of awareness and education across the piece around Delta. Delta is an orphan disease, and both hepatitis B and Delta, which is obviously an obligate virus associated with hepatitis B, suffer from that lack of highlighting of the severity and their understanding in the processes of linkage. So very much you and I both agree that we should be testing every single hepatitis B new diagnosis for Delta. The guidelines actually differ right now between the European and American guidelines. In the American guidelines, they talk about selected high-risk factors. I would disagree with that. So sorry to take you back, but then to go to your question, and this patient, our hypothetical patient, I agree with you that some of our colleagues are much better now with the awareness of bloodborne viruses and a screening for Delta. A patient who has a Delta virus that's positive on antibody certainly needs to be seen in a specialist hepatology or infectious disease environment. And as a hepatologist with an interest, I'm going to suggest a hepatologist. When those patients come to clinic, and again, we need to think about the epidemiology of these sorts of patients, we need to ensure that they have an easy way in to specialized care. I might throw it back to you, Graham, to talk about the types of patients we see with Delta and some of their challenges, and then I will come back to what we think the diagnostics should be.
Yeah, the Delta patients are interesting, aren't they? They very often have histories of living abroad. They're niche, and it's fascinating to look around the globe and see little pockets of Delta. In Brazil, obviously, in parts of Iran, large amounts of Delta. I was talking to a very good friend from Pakistan, and there's a little belt of Delta virus in Pakistan where nearly 20-30% of the bees are Delta positive. And then you go up into the north and people never see a Delta case. So it's a very odd, uneven distribution. The other group that we do need to think about with Delta, of course, are people who inject illicit drugs. And this is very much a disease of immigrants. It's very much a disease of illicit drug users, very often associated in some of our sex workers with HIV as well. So it's a disease of disadvantage. And these are the patients who are very often rather difficult to engage with. They're reluctant to come to the clinic. And you're a lovely, warm human being, Kosh, and everyone loves you when they meet you. But that officious looking letter from Dr. K. Agarwal or his team will see you at his leisure. It puts people off. And I think the tricks we've learned with hepatitis C about getting these people in. So I would very much like to think about some outreach work that we need to be doing with the groups at risk of Delta. But let's perhaps go to how we get them to go through the tests when we thought about what they need doing. So where would you go first? I guess it's venous blood, isn't it? We've got to get.
I think it is, first of all, exactly as you say, they're challenging groups of patients, and we need to provide a model of care that allows them to interface well to get that specialist care. The assessment of Delta patients always clearly starts off with the assessment of their virology. We want to do a confirmatory antibody, and we would always do a Delta RNA, and we could probably batten forth the difficulties with the diagnostics and the reproducibility, certainly, of RNA. At King's, we will also do a genotype, and we can probably not talk too long about the impact of genotype, although there is an impact there. And then, of course, we need to do our liver functions profile. We want to check for other viruses such as HIV and hepatitis C, obviously characterize the hepatitis B status and DNA, and then clearly do a fibrosis assessment. So for me, it is that approach to provide information in the right way from a cultural perspective and an educational perspective. These patients are younger, these patients are very fluid, but also to explain to them that we need to provide an assessment via blood test and then FibroScan assessing their virology and then assessing their level of fibrosis. How do you compare the Hep Bs to the Deltas in their presentation and their level of fibrosis, Graham?
No question, Kosh, that the Deltas are the dangerous one. They're the ones that go, the rampant. It's not always, and certainly we've got a little handful of Deltas who seem to be fairly quiet, but the vast majority are getting cirrhotic in their 30s, 40s. They blow up cancers at an early stage. And I think that makes the diagnosis much more challenging. I worry about FibroScan as being overcalled. A lot of the Deltas have got these high transaminases, which sometimes fouls up your FibroScan. I think APRI is a great screening test for cirrhosis. Not entirely sure that with these high transaminases we see, it's quite as reliable in Delta. I don't like liver biopsies. I think it puts people off. But I think we should certainly be aware that progressive fibrosis is to be expected. I think getting these people from the street into services is where we run into trouble because it takes a while. And by the time you've done the RNA and they've gone back and they've come back for their RNA, and by the time they've had their FibroScan and then they've had their ultrasound, people are drifting away. And I think one of the things we've learned from the hepatitis C profile is that if you have vulnerable patients who are disengaged, you've got to do it in one go. And I think one of the problems we have with Delta is we don't yet have a good point of care. And certainly in the settings where people with Delta are likely to be found, immigration centres, people in addiction services, people who are perhaps less eligible for healthcare, you probably get one shot to make all the diagnostic tests. And I think that's a challenge.
I agree with you. I very much like the work that you've led nationally in England for hepatitis C and that outreach perspective and that support system to try and ensure patients are linked in. For me, it really, the rubber really hits the road for these Delta patients because they're younger. And certainly in my experience, a significant proportion of them present with cirrhosis. So keeping them in the service, whether they have immigration issues or place of residence issues, I think is critical as they go from place to place. And we see this across London. They're younger and they're mobile, but that is the characterization of this population. I would agree with you that we need to try and one-step it, but I would slightly alter my view around the view of liver biopsy. I think liver biopsy is going off the paradigm for our patients with viral hepatitis, but there are a group of patients who have a significant autoimmune component to their Delta. So on occasion, I will consider biopsy, but I agree most of the patients, certainly in a sort of regional referral practice environment, we see have this preponderance of advanced liver disease, cirrhosis, and then we're already really struggling to explain at a young age, often with a different language. We see a lot of Eastern Europeans and we have a lot of Sub-Saharan Africans coming with previous exposure or active low-level Delta. There is a bigger mandate to keep them in the service and to try and get therapies of whatever sort and monitoring for liver cancer established for them. So that linkage piece in Delta really sits above as a priority what we've done so well in B and are starting to do in C and are starting to do in hepatitis B.
No, I agree. And I know you have extremely good links to the African diaspora in Southeast London. I remember years ago going to one of their meetings. They're a very engaged bunch. Do you find them useful as peers, as advocates? Is that a trick that you've used to get these people engaged?
We have not taken that as far as we should have done. That's a really good question. I think for both B and Delta, but today we're talking about Delta, having culturally similar peers or sources of information, I think is critical. I think, as you've alluded to, there are pockets of Delta that we see from different environments. We see some Italians from southern Italy. We have that sub-Saharan Africa swathe of predominantly genotype 5 Delta. We see Eastern Europeans, as do you, that come with Delta. We have to think about the appropriate kind of commonality for these patients so they understand it. But actually, we're not even as good as having the information in the right language. So the linkage to care piece is so critical as we really need to think about surveillance for HCC. And I was going to ask you about monitoring and your feelings about that and treatment for hepatitis B in the context of Delta, but then to think about other options and concerns that we might have. But we need to be much better. And I agree with you. We're now spending quite a lot of time following up our patients to ensure that they have their appointments, ensure that we have their points of contact, because the pathway isn't user-friendly as it needs to be.
Yes, I'm interested. You obviously get a lot of these advanced liver disease deltas who are fairly quickly going on to transplant, and those conversations with that 35-year-old who suddenly realizes that he's in a really poor shape. What sort of support are you offering for those guys as you work them up for grafting? These delta patients are tricky.
It's a good question again. So the world of transplantation is evolving. I have had clinical experience of patients really rapidly deteriorating with Delta. And also we have to talk about their risk of HCC, which is significantly increased. And oftentimes our radiologists really need to see or feel reassured only by MRI or CT cross-sectional imaging because of the way the nodules are formed in Delta. So we are very anxious about these young patients who are sitting with a degree of decompensation. And my personal practice is that if they are starting to reach those criteria to consider listing, we put them within the assessment pathway. To answer your question, when they're coming towards that assessment pathway, we're seeing them fairly frequently. We have our own transplant coordinators. We have our social worker who's attached to the team. I'm embarrassed to say we don't have that same sort of resource for those who aren't in the transplant pathway, but we try and make it as seamless as possible. I can give you the example of a patient we saw from Romania who is actually one of our patient advocates. So we do have a patient advocate from Romania with Delta who is helping us and supporting us as we've talked about. And she has only had a degree of ascites, is very under the age of 50 or much younger than us. And we felt that she should be listed. So she is being followed up locally. We see her fairly frequently just to make sure that that linkage to the transplant pathway, the surveillance, and to make sure that she's appropriate and she's not deteriorating is really kept under tight review. But when they come to transplant, it starts to become a bit of a different kind of discussion. My worry is when we see patients who are referred a little bit late and when we have a paucity of any therapy options for them.
I was really picking up on the transplant because for me, there is this inequity. Once you've got end-stage liver disease, we throw the book at you. We throw the social workers. We get your license to stay in the UK sorted out. You get the whole package. But if you've just got Delta virus at a treatable stage, then you're pretty much left on your own. And I do think that we need to start thinking and going back to better support for people earlier on.
You very cleverly teased that out of me, and you're completely correct. I've shown you all the resource we had for transplantation, but fundamentally, we're very good at the end stage of hepatology. We're very bad at optimizing health and identifying early, which is both a strong passion of yours and mine, that we need to identify these patients early, but then link them in. I'm not happy to have these patients and then send them away. For patients with hepatitis B and Delta, they need to be seen in a specialist center. They need to understand, however we need to work harder that they have that understanding of the severity of it, that we build in the rest of their social, economic issues so that they can attend. And most importantly for me, when they have advanced liver disease, it's ensuring that they're engaged with regard to follow-up and risk of HCC and having appropriate HCC surveillance, and when new therapies may come through that they are suitable for.
You keep touching on the HCC risk, and I think that is, for me, one of the biggest concerns. And I always get very anxious about the Delta patients. And your comment about the nodular liver is it's the one that we end up doing MRI scans. Getting people engaged in cancer screening is as hard as anything that I've done, and I find it very difficult to keep patients every 6 months. Firstly, because whenever they miss an appointment, we throw them out of the screening. They get fed up with it. They have holidays and they miss things. We've been, as you well know, thinking about fibroscanning in the community to pick up cirrhosis, but you've gone a step further. You're putting ultrasound machines on vans, if I'm not mistaken. So what are you doing with that to drag people from the streets to have a scan?
I think it's Albert Einstein that said that if you continue to make the same mistakes, you know, it's the very definition of being an idiot. It's a malapropism, and I've not taken that quote properly. But in essence, we need to think about the way we deliver care in a radically different manner. And one of our challenges in a newer pilot that we're doing in London is to see what the acceptability is of putting a portable ultrasound scan on one of our diagnostic vans to take the ultrasonographer and the equipment to the patient. It's a lot of effort, but we've seen it really work, that outreach work in hepatitis C, with great effect. And I do agree we need to widen this for other aspects of hepatology. And I would say as a specialty, hepatology needs to be much more outward looking into the community for early identification of all aspects of liver disease. This discussion is about Delta. So of course, Delta, but then to identify those with advanced disease and then to see how we can pull them into care and to provide that appropriate linkage to care for them.
Yeah, I think it's interesting to wander around a hospital you're not familiar with. Very occasionally I trot from the Royal London, which is base camp, over to St Bartholomew's when they've got some liver patient on their cardiac ITU. And actually finding your way around a strange hospital is extremely difficult, even when you have the self-confidence to grab a nurse and ask, and the answer is, I don't know where that is, and they run away. So I have a lot of sympathy for patients navigating a hospital environment, particularly with the type of patients we're thinking about, the poor English, often feeling marginalized, often anxious. So taking the treatment out is probably the way to go. My challenge really, I think, with Delta is it's the one hepatitis virus that is most difficult to manage out in the community. We've talked a little bit about the lack of point of care tests. You've talked about the challenges with ultrasound. They're probably the patients that need to get into hospital to see that specialist. And as you say, the local average jobbing gastroenterologist with an interest in liver disease is not going to accumulate enough Delta patients to get a feel for them. And I think with all medicine, you need that feel. You need to have seen a batch to see how bad these patients can go and how quickly, just to get your eye in. So I don't quite know how we resolve that tension between quality care and local care.
I can't help you with that, and I agree with you completely. We are lucky enough to live in London, and London is that global village with its wonderful ethnic diversity, its mobility, its perhaps younger population that comes with these high risk factors, particularly of B and Delta. And the idea of managing these conditions with a interested gastroenterologist, or at the end of a gastroenterology clinic, is not viable. So it's that tension between the hepatology that needs to be seen in an outreach or a community interface with the early diagnostics, widely available and interpretable diagnostics, plus then having enough expertise, which is certainly there at the Royal London and hopefully at King's, where we have a cohort of patients and we have a sense of how we can manage them. So that for Delta, because the numbers are very variable when you look at the studies of incidence and prevalence, because of the level of diagnostics that the population studied for screening is very variable. But we're not joined up in our data. We're not joined up in making the case. And I think it is the exemplar of the challenges of hepatology, because again, as you know as well as I do, this is an orphan disease when it comes to therapies. We see this as the difficult virus and the dangerous virus, as you very nicely characterized it.
You make a good point about treatment, Kosh. There's no point in linking people to care unless you've got something to offer them. And in many cases, that offer of potential treatment is what engages people in the care cascade. I go back to the good old days when I was giving people interferon 3 times a week for a couple of years, and it did very little apart from making patients sick as dogs. But I think we're starting to see opportunities for real movement in treatment, aren't we?
I think we do have to talk in the context of linkage around therapies. Again, you've lived the dream. The world of hepatitis C pivoted once we had directly acting antivirals with regard to getting patients into treatment and keeping them engaged. So therapies really changed the dynamic of care of what we can offer as a multidisciplinary team, and likewise for patients. It gives them that something special that they can feel that they're coming to clinic that's more than just monitoring. I agree with you about interferon and delta. It's cheap, it's licensed, we know how to use it, but we excluded interferon from hepatitis C many years ago now, and I'm not so sure I can see that there is real value in the use of interferon for delta at all. I think as we talk about treatments, we need to think about diagnostics, which is a problem, and then I think we look forward to the potential of newer drugs currently available in Europe for those patients with compensated cirrhosis, but is quite a challenging medication to take. It needs to be drawn up every day, and it's a subcut injection with or without interferon in different trials, with normalization of LFTs and suppression of delta. We still await the phase 3 studies and licensing on a more wide basis. But then we look forward to newer therapies in the context of Hep B trials and new modes of actions of drugs. So I think it's a very positive time, and we do need to work together regionally or from a countrywide perspective to at least have the numbers of patients in front of us and to provide a consistent offering.
I think that's absolutely right, isn't it? It's an equity issue. We've got to make these treatments available to all who need them rather than those who happen to speak the right language or live in the right addresses. So we've got a lot of work to do, Kosh. I will let you get on and go and heal the sick while I go back to putting my feet up. But always a pleasure to talk to you, and look forward to the next iteration of the Delta story.
Thank you very much for involving me in a fun conversation, Graham. Nice to see you.
Thank you very much to Dr. Agarwal and Dr. Foster, and thank you to our listeners for joining in. As a reminder, to view the full Don't Delay with Delta program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.